So my topic today is pregnancy in a KT patient. And my life was made easy because there is very little literature to read around this topic, because there are not so much cases reported. So my outline of my talk will be I will discuss a case and then outline on relevant timing of pregnancy and the outcomes and complications and the drugs which are safe and unsafe. So we'll start off with the case to break the lethargy. So this patient I've encountered during my training period under Dr. Chula Herat at Sri Javadharpur Hospital. So she was a post-KT lady who had a primary renal diagnosis of chronic interstitial nephritis among the agricultural communities, but her hometown was Kurunegala, but somehow her biopsy have shown a chronic tin, which had been done at Kennedy Hospital, and then she had been on dialysis, I think about just a couple of times, when she was preemptively planned for a altruistic kidney transplant in 2012. So when she conceived with this pregnancy, she was post-kidney transplant 4 years plus 8 months, and she had pre-pregnancy planning and counseling and a lot of preparation towards this pregnancy. So anyhow, when at her pre-pregnancy level, when she was conceiving, her baseline creatinine was fluctuating between 0.9 to 1.1, and her blood pressure was well controlled, and UFR did not show any proteinuria, and these were the drugs that she was on when she was conceiving. So prednisolone, small dose, tacrolimus, recent TAC levels had been done and checked, it was 4.9, and she was on iron, folic acid started on time, and thyroxine because she had hypothyroid history, and some calcium. She was off MMF anyway due to a BKV viremia she had more than a year ago, and afterwards the BKV had cleared from her system, but MMF had been kept off because she had been running good creatinines afterwards. And she did not have history of rejection, had quite stable graft function, and was on stable doses of immune suppression. Her baseline investigations, including liver, uric acid, calcium, and TSH were done, including cultures which were normal. So I'll just take you through the case. Right. So what we have to keep in mind, which I'll be talking in my next few slides also, regarding tacrolimus. So pregnancy causes differences in tacrolimus metabolism. It has increased volume of distribution and there is increased metabolism, so therefore TAC levels tend to decrease during pregnancy. So as you can see, due to many factors, we can't really conform to the guideline measurement of tacrolimus every 2 weeks beyond the second trimester. So we have done as frequently as possible according to what we can afford. So her TAC levels fell in her second trimester, for which doses were incremented gradually. And postpartum, we have maintained TAC levels until the TAC levels picked up. I have not mentioned further sequelae, but we have followed her up onwards, which now again the TAC level could be reduced afterwards, as I remember. And the DSA is called donor-specific antibodies. That is, when we do a transplant, we do the HLA status of the donor and the recipient, and then we can assess whether this particular recipient has the tendency of developing donor-specific antibodies for this particular graft. So generally, if you have a foreign life introduced to you, you are bound to develop antibodies, but when you are doing a transplant, we start immune suppression as soon as we introduce this foreign thing into a person. Therefore, we knock down the immune system. So we expect the antibodies not to develop unless we are not able to suppress certain development of antibodies, or maybe she has a past exposure or sensitization. So therefore, in that case, that memory cells get activated and this particular donor has that particular antigen. So therefore, from time to time, they can have donor-specific antibody surges coming up. So in this lady, we were able to perform donor-specific antibodies when she was approaching T3. So at that point, creatinine was more or less stable, but we would say she would have had a better probable creatinine because of the volume of distribution is different at this time of pregnancy, so therefore the creatinines probably in the T2 may have been lower ideally. So it may not have been 0.98 if not for these donor-specific antibodies, probably we may say. So we measured the donor-specific antibodies and we tried to optimize the immune suppression during this time, and postpartum it was like this. So just to complete her story, she delivered a healthy baby at 35 weeks plus 4 days, and the baby was a good weight. And post-delivery, her creatinine at 3 months postpartum remained at 1.04. So all her problems started actually after delivery, because we know, as I will go into the theory slides next, there is more tendency of developing UTIs and graft pilus post-pregnancy in these patients, even during pregnancy. So she didn't have any problems during pregnancy, but after pregnancy she continued to develop multiple UTIs over about the next couple of years, which was well managed with antibiotics, and prophylaxis was put on for long term. And 1 year, 3 months after the delivery, she had a ABMR, that is antibody-mediated rejection, which was treated with plasma exchange and low-dose IVIG. But it did not resolve with this treatment after 3 months when we checked the DSAs. Then a second plasma exchange was given with high-dose IVIG and then followed by rituximab. So this removes this plasma exchange, and IVIG removes the existing antibodies from your system, and we give rituximab so that we try and suppress any further production of new antibodies. That is the reason we try to give rituximab in these patients when we are aggravating immune suppression. And then she continued to have 4,000 odd donor-specific antibodies continuously. So therefore she was treated with monthly IVIG cycles. 15 cycles were given over 15 months. And then so currently she is not residing in Sri Lanka at the moment, and I was able to contact her, and she's having a good graft function at 14 years plus of her post-KT life, and with a recent most creatinine of this much, and she's on these drugs. So just a word on prevalence. So in the literature, there are about 14,000 pregnancies reported so far worldwide up until 2001, as reported in this article. So they also say that these were just picked up from certain registries. There are only, I think, maybe about 4 or 5 active, very comprehensive registries at the moment, maybe USA, UK, New Zealand, and European. So those, and then with the case studies and case reports and case series from others, so about this much. Maybe it had been underreported. Why I'm saying it's underreported, because now this was the first pregnancy in a renal transplant patient. She's Edith Helm. So they were twins. This was the first renal transplant in the world. So transplant happened in 1956 and she got pregnant by 1958. And she has had 2 successful pregnancies, and she has deceased at 76 years of age due to dementia, a non-renal cause. And her twin sister, who's the donee, has had 4 successful pregnancies after this donation of the kidney. So this is how the history was when our knowledge was so much less, and I think the drugs were also so much less. So maybe there were so much pregnancies happening those days in transplant patients which were not reported. And in the literature they say after introduction of MMF after 1990s, probably the pregnancy rates would have become less because of the advice given, don't become pregnant while you are on MMF, and you need to be on off MMF to conceive because of teratogenicity. So it's important to know the timing of the pregnancy after doing a renal transplant. Best recommendation, this was given as best in the European literature. American Society of Societies say that post 1 year could be the best time. So there are for and against. So maybe either beyond 1 year, and still I think the best recommendation is probably close to the second year of the transplant. And if you're, because there are certain papers which say that now the pregnancies are happening in quite advanced ages. So therefore, transplant people. So therefore, if they are already of advanced age, maybe they can't stay for 2 years. In that kind of scenario, maybe advising them they can become pregnant after 1 year could be feasible. But before we say such advice, we have to make sure that they are on stable doses of non-teratogenic medications. I will elaborate on this in the next few slides. And the creatinine, the graft function should be very stable and ideally less than 1.5. And the proteinuria status should be under control, and probably if the proteinuria is there, there is more risk of graft decline. That is why they say no proteinuria or less than 500. And not having fetotoxic infections running. Some people may have CMV viremias, and no rejection episodes during the past year. So why do we advise them to avoid within the first year? That is, their rejection rate can be high, and immune suppression medications are at their highest doses. During the initial 6 months of transplant, we give them aggressive immune suppression doses, which taper down to a most needed level. So we keep on the sort of prolonged maintenance levels. We start tailing them down after the first 6 months. So by about 1 year, they have reached their stable immune suppression doses. So and the infection rate is also very high because they are on high immune suppression doses. That's why we say to avoid within the first year. So who are more likely to develop these complications? Higher pre-pregnancy creatinine. So beyond 1.5 creatinine, there are studies which say beyond 1.3, beyond 1.5, and some say beyond 1.8. So anyway, let's take the middle number, beyond 1.5, you have more likely to have graft decline. So those are more likely to develop complications. And people who don't have already controlled blood pressure may anyway have problems controlling it further. And when they are proteinuric also, they have problems. So when pregnancy occurs beyond 2 years post-transplant with a normal baseline graft function and well-managed BP, the rejection rates are similar to non-pregnant controls. The complications that can arise is for the renal allograft, as we all are worried of, decline of the existing renal function. This happens more when the pre-pregnancy creatinine is generally either 1.8 or more. There is risk of premature graft loss for such patients. And there is more difficulty in managing their blood pressure, and they are more prone to get UTIs or graft pilose. For the pregnancy itself, the complications would be more incidence of pregnancy-induced hypertension, preeclampsia, premature delivery, IUGR, low birth weight, or gestational DM. Could be drug-related. So what are the outcomes? So these are the percentages that is reported. So usually in post-transplant patients who are pregnant in the databases, 21% may have preeclampsia, 24%, 1/4 may have pregnancy-induced hypertension, and gestational diabetes in about 6%. For the fetal, so the live birth rate is about 73% in most meta-analysis that have been produced, and miscarriage rate is 15%, induced abortions 12%, and so forth. So with a good graft function, more than 95% of pregnancies which progresses to more than the first trimester usually has a successful outcome. Pre-pregnancy and antenatal care, so we have to optimize the when we are planning for the pregnancy for that particular patient, we have to make sure that we have optimized their blood pressure and well controlled, and we have optimized their immune suppression, and they are started on folic acid on time. And aspirin probably after 12 weeks of conception to reduce the incidence of preeclampsia. I think a previous speaker elaborated on this. The TOT screen may be the rubella status, because after kidney transplant anyway we can't give rubella vaccine because it's a live vaccine. So maybe we have to be aware of these things. And then virology status. So because CMV positivity is a congenital infection, and there are very little that we can do once they get it. Rhesus negative mother having a rhesus positive graft may have had antibodies developed against this rhesus positivity in the graft. So therefore, if the baby that she has conceived with is rhesus positive, they have probably have problems with the baby in tri-tribe. So we do urine cultures also with UFRs every visit, because asymptomatic bacteria should be, as in pregnant patients, should be treated promptly with 14 days of antibiotics, and then there are these guidelines say that we should put them on prophylaxis. So until 24 weeks, this is the usual pattern of reviewing them. Initially, we reviewed them every maybe 3 weeks, but beyond the second trimester, we reviewed them once in 2 weeks, and beyond that, weekly. So drugs which are safe, prednisolone 5 to 10 milligrams is considered low dose and fairly safe in the long term in pregnant people. And the calcineurin inhibitors, cyclosporin and tacrolimus, as I mentioned earlier, they need higher doses, usually in pregnancy, because their GI absorption is less, their volume of distribution is more, and their renal clearance is more. So therefore, close monitoring of tacrolimus level is essential, because otherwise the graft may go into a rejection episode because of low immune suppression levels. There's a remote possibility reported of low birth weight and premature delivery due to CNI, but it doesn't negate its use. Azathioprine less than 2 mg per kg per day is considered safe in pregnancy. Higher doses may have congenital anomalies and so on. What are the drugs which are unsafe in pregnancy? MMF is a no-no, because why? There's teratogenic. There are fetal major malformations like hypoplastic nails and so on and so forth, and it's contraindicated. Sirolimus, we have to best to stop at least 12 weeks before because of fetal toxicity. So better if the patient is not on adequate contraception, the papers say we should advise against pregnancy, and we should advise them, and we should not be prescribing sirolimus, and we should make sure that they get a proper contraceptive method before we prescribe sirolimus. And ATG, basiliximab, alemtuzumab, and antifungals, valganciclovir, all of these have known to cause problems in animal studies, but human studies are not actually present for ATG and so on, but they've asked to avoid these drugs in pregnancy. How to manage a rejection episode in pregnancy? It may be quite tricky to diagnose rejection. So therefore, when there's a creatinine rise, we have to carefully assess what could be the cause. Is there graft tenderness? Is there oliguria? So could it be an infection? Could it be rejection? So after careful assessment of whichever way that it could be, they say we should ideally consider renal biopsy before considering treatment. But if rejection is diagnosed, we can treat with methylprednisolone pulses, and along with optimizing the tacrolimus levels. Delivery, so cesarean section is usually for obstetric indications, not really due to a kidney transplant. So when you are doing vaginal examinations, you should make sure that you use strict aseptic methods, because we might introduce infection to them, and the stress doses of steroids during delivery. And we should not interrupt the immune suppression like tacrolimus and so forth. We should continue those baseline immune suppression. We should not stop them. It's just conversion of the steroid to the stress dose. Breastfeeding and immune suppression. So during breastfeeding, the data remains controversial, because the things that we can give, the tacrolimus, so now while the patient is on tacrolimus, some studies say that you don't excrete so much in the breast milk, so therefore it's negligible what the neonate gets, so therefore you can continue breastfeeding. It's not absolute contrary, but certain studies say that there is certain TAC levels, if you do in the neonate, you do find TAC levels, so therefore you don't know whether it messes up with the brain. The FK506 of the tacrolimus might go and cause cognitive problems in the child, which are not proven, but this theoretical. And also, so therefore, I think current evidence says that they can't really recommend to continue recommend breastfeeding for a mother who's on immune suppression post-pregnancy, post-transplant. And MMF, sirolimus, human trials are lacking. Prednisolone, azathioprine are detectable in the breast milk, but they are considered safe to continue during lactation. But generally patients who are post-transplants are usually on a CNI. So therefore, although these are considered okay for lactation, we still recommend against breastfeeding on a post-transplant patient. Another case to just wind up the presentation. So 35-year-old, this I've taken from a case report actually. So 35-year-old post-KT 9 months patient. This is a classic practical scenario which may come to you in the clinic. So they've had a cellular rejection episode 3 months ago, which had been treated by a nephrologist with steroids, blood pressure in the margin, creatinine 130, value, okay, and they are on these drugs. So they want to conceive and is asking you, can I? What would be the answer? So in this kind of scenario, we advise them, they are post-KT 9 months. They've had a cellular rejection already and had been treated. So would say we have to optimize the immune suppression, and after now we have managed the rejection episode anyway, we have to, I think, ideally another at least 1 year probably see whether they are stable and not developing any other rejection episodes. And so that the graft function creatinine remains stable. So folic acid needs to be started 3 months before when we are really targeting that, and we have to check the urine protein creatinine ratio, and they're already on MMF, enalapril, alendronic acid. So we probably have to convert this MMF to azathioprine and see whether they will develop another rejection or not, probably monitor with DSAs and so forth, and then probably prepare them about close to a year after this visit. Thank you.